All right, good morning, everybody. Let's take a look at some specific pediatric emergencies that you'll need to be aware about. There, as we talked about, there are some major differences between the pediatric patient and adults. You're going to have more challenges depending upon the age of the patient in getting your history because the really young folks are not able to communicate really well. And even as they get a little bit older into preteens, early adolescence, and in adolescence, they may be just kind of afraid or embarrassed to talk to you about the situation that's going on with it. They're afraid maybe it's from a sexual issue or maybe from the point that they just feel like that they're going to get in trouble if they say anything. One of the things you want to keep in mind, and you don't want to be overly paranoid about this, but you want to remember that there's always a possibility of child abuse going on, especially in trauma when the story doesn't add up to the injury. So it could be that the child is hiding something from you as the caregiver that would have a problem as far as leading into that. The thing to remember is when kids have a problem, especially very young kids, it's usually going to be respiratory centered. It's not going to be primarily cardiac centered, much like we would see with adults. Now, don't forget, kids can indeed have cardiac issues, but that's the exception and rather than the rule. Now, there are a couple of terms that you will see on my exam as well as potentially on the registry exam. And it was previously called, when we have these situations, an ALTI, an apparent life-threatening event. For whatever reason, I don't know why, but it has been changed over to now a brief, resolved, unexplained event. Now, what this means is that something happened. It triggered an emergency response from the parents or the caregivers. And now when you get there, generally it has been taken care of. One of the most common situations that you'll see this in is going to be with a child that's had a febrile seizure. Generally, I would tell you I could probably count on one hand the number of children that I've seen actively seizing, because generally the seizures last for a few moments. It scares the parents to death, rightfully so. But by the time that you get there, the issue is over. It's been resolved. Now, again, don't confuse this with SIDS. SIDS is sudden infant death syndrome, and generally, and we'll talk about this in a minute, but generally that is going to be resulting in a fatality. Usually, an incident of brew is going to involve some type of respiratory problem. Again, seizures, difficulty breathing, short periods of apnea. Patient may become unresponsive. Cyanosis may come into play there. And almost always they're going to experience an altered level of consciousness. Now, there are a couple of things in here. Number one is that even kids can have gastroesophageal reflux. Acid comes up out of the stomach. It burns the esophagus. Maybe some of it gets there at the glottic opening. And now that's going to cause the child to have a respiratory issue. The vast majority of these are going to be neurological episodes coming from a febrile seizure or potentially early onset of a drop in blood sugar or in the drop in the oxygenation from a seizure. Again, when you're looking and assessing these kids, don't forget the potential for child abuse that's going on. Again, I want to stress to you, don't go looking for child abuse in every pediatric call that you go on, but keep it towards the front of your mind. So, SIDS, sudden infant death syndrome, is an unexplained event in which the death of a child occurs, and based upon both the history of the patient and the autopsy report, there is no cause of death. Now, one of the things that we've seen here is that a recommendation was made several years ago to put kids on their back to sleep. Basically, the mantra was put your patients back to bed. And so we've seen a decrease, a dramatic decrease in SIDS deaths as a result of this. There are some theories that maybe there's been a precipitous drop in their blood sugar and that's caused them to stop breathing. But then again, that would have shown up on postmortem as far as any of the lab exams that go on. There are some risk factors that you want to take into consideration. There's nothing good that comes from being exposed to cigarette smoke. Secondhand smoke, as we're all very aware, is even more deadly than primary exposure. Mom who is younger than 20, and this does not go into the saying that moms that are younger than 20 can't be good mothers, but there's a physiological process what's in there. And the other thing that we're looking at in addition to the ones that are on here is this soft bedding. So there's a potential that the baby, remember, they don't have really good neck control as far as their muscles, and they may get their head into this soft bedding, and as a result of that, now they have a suffocation incident. Now, interventions such as putting the baby back to bed has decreased the incidence of SIDS by 50%. But now there's still no decrease as far as instance of a brief resolved unexplained event. It's interesting that most of these events happen during the daytime hours from 8 a.m. to 8 p.m. Researchers really don't have a good reason as to why that is, and they're continuing to study that. The big issue we're looking at here is upper airway obstruction. Now, here's a key thing to remember. I promise you will see questions like this on your final exam. If you have a child that is toddler age, no fever, no history of illness, and mom or caregiver puts the child down on the floor, and then they have a sudden, rapid onset of respiratory distress, quite often accompanied by stridor, the first thing you need to be thinking about is upper airway obstruction. Their airways are very small, as you're very aware, and they can become obstructed really, really quickly as far as anything that comes into play. Some of the things that we see here, are epiglottitis. That's on a decrease for kids that get the vaccine. Again, keep in mind that even older children can get epiglottitis, but normally we see this in kids that are younger than 4. The big thing that we see with all of those diseases that you have listed there as far as an infection is that it brings up, as well as most of the other bullets that are listed in here, is that it brings about, number one, bronchoconstriction, and, wait, there's more, edema from the inflammatory process. When we're looking at epiglottitis, again, just as a review, it is a swelling to the epiglottis that causes a big problem with the blockage. Now, remember, in the young children, the epiglottis is large, it's floppy, it's U-shaped. And so one of the things that we see here is that it's going to have a rapid onset, and this almost always occurs at night. Again, we've had a decrease in this since the vaccine has been introduced a number of years ago. I want to stress for you one more time, and it's not because I'm forgetful, but it's because it's important. Normally you'll see this in young children, but it can occur in older children as well as in adults. And this is a fairly good picture of the X-ray of the epiglottis, showing how large and floppy that it is and how it can actually fold over onto the glottic opening, causing an airway obstruction. Another good shot of the epiglottis, that on the left, it shows that the epiglottis, swollen, almost has a complete blockage of the airway. In this situation, you can tell you're not going to be able to pass even a small airway. In many situations, you're probably going to wind up having to do a surgical airway, which is a really highly Dangerous procedure in young children because remember, they don't have the tracheal rings that'll help you to be able to identify the landmarks. So try to keep them calm. Take them out in the cool air. Try to keep them from crying. And unless you absolutely positively have to, don't start an IV on them because guess what? First thing they're going to do when they see that needle, they're going to start crying and that epiglottis is going to close over. Croup, the medical name for this is laryngeal-tracheal bronchitis. And basically what happens here is we have some edema and swelling down that are below the vocal cords. Now, with kids that have croup, or again, laryngeal tracheal bronchitis, they have a really, really harsh barking cough. Now, this leads into, especially if it lasts more than 5 days, that you may literally get a call for a 7 or 8 year old that's having chest pain. Again, don't be misled into thinking that, okay, this is going to be a cardiac issue, when in reality, it's actually going to be a respiratory issue. Just by way of reminder, keep in mind that cardiac pain does not change with respiration or expiration, and neither does it change with movement. With croup, you will begin to see this type of process as well. This is just for your knowledge. Basically, what you're looking at here is on the right, another x-ray where you can actually see inferior to the larynx where that is beginning to close off. It's called a steeple sign, and you can see that you're not going to get a lot of air that's going to move in through that particular area. So that kind of gives you a little bit better visual of what it's actually going to look like. Take a look at these different types of symptoms that you're generally going to see as far as the difference between epiglottitis and croup. The big thing to remember with both of these is you're going to have a fever, you're going to have some respiratory issues. With epiglottitis, generally they'll sit in a tripod position and they'll drool because it hurts to swallow. With croup, you'll have that seal-like cough along with it. Both of these can indeed become a life-threatening problem. Bacterial tracheitis is an infection of the trachea, and generally what we're going to see here is the child is going to have run some really, really high fevers. Now, generally this is going to be seen in kids that are older than the ones that would either have epiglottitis or the ones with croup. Again, the big issue that we're looking at here is we're going to see edema of the trachea, which is potentially going to reduce the passage of airway. In this situation, again, cool, humidified oxygen is going to be your best treatment for this particular patient because we know that cool, moist air will help to reduce inflammation. A retropharyngeal abscess is basically we see an abscess that can begin to compress the airway. This can come about as a result of problems with tonsils. Generally, what we're going to see here is a patient will complain of a sore throat that gets worse. They'll have neck pain, primarily on one side or the other. Now, the airway obstruction that comes about with this particular disease process doesn't happen quickly as what we would see with a child that picks up something and puts it in his mouth, but it is chronic. It is long-term, and generally what we're going to see is depending upon how viral the abscess is, it can occur over 3 to 5 days with respiratory status getting worse. Mononucleosis is not very common anymore, but basically what we see here is that the tonsils now begin to enlarge. The mucosa in the posterior pharynx also begins to swell again because of the edema from the inflammatory process, and as a result of that, we could potentially have an airway issue. The big thing again that we do here, cool, moist oxygen for our patient. Kids are putting things in their mouth all the time. And so the thing that we want to remember about with this is that if we have a sudden onset without the report of an illness prior to that. The first thing you want to think about again is an airway obstruction. Generally, with these, if you can't get it out, try to right main stem it, blow it into the right main stem bronchus so that at least we can ventilate the left lung, and that will generally be sufficient for oxygenation until the patient can get to the hospital. They can do a bronchoscopy and things will be taken care of. Thermal burns bring a whole different issue from both a circulatory perspective as well as a respiratory perspective. We see the swelling that begins in the upper airway first, and it can be the lower airway, especially if we're in superheated air, as what we would see with steam. Assess your patient for hoarseness. Look for charcoaling or soot around the mouth and the nose. If they're complaining of neck tightness, or if they say that they're beginning to have some difficulty breathing, go ahead and get everything ready for the potential that you're going to have to do a surgical airway on these particular patients. Listen to their breath sounds frequently and assess for the potential for wheezing. Albuterol, not a bad drug in this situation. It will do nothing for the edema from the swelling, but it may lessen the bronchoconstriction and save the patient's life. Altered mental status can come across primarily from infections or from the child taking something. Either they pick it up, toddlers looking at grandma's beta blockers, they look colorful, they look like candy, and now they chuck them down, and now we've got an unresponsive child. Or it could be something older with children, again, adolescent or pre-adolescent that are experimenting with drugs. Within this, again, look at your metabolic potential of the diabetes being there with a hypoglycemic issue. All altered mental status patients, regardless of their age, get a blood sugar check just to rule that in or to rule it out. When we're looking at this as far as newborns and infants, they have a really immature immune system. It does not do well, and so they can develop these infections really quickly. Now, again, remember there could be some trauma involved because, again, a crying child, even though I like to say a crying baby is a happy paramedic, a crying child for days on end, and that has a tendency to grate on your nerves. That's not excusing trauma, but that's the thing that you want to begin looking at as far as when you're assessing your child. Generally, what we see as far as an altered mental status is going to be subtle changes with these kids. And so look and get information on the assessment and the history of your patient over the last several days. In many situations, the caregiver is just simply going to say, I can't tell you exactly what's wrong, but there is something that is wrong. And so, again, start from there and work through this list of potential things that would be a problem. Again, when kids become toddlers, now they begin putting all kinds of things in their mouth. And as a result, now they like to act as their parents, and so they see their parents putting medicine in their mouth. Maybe they'll do the exact same thing. When we're looking at this, one of the things that you want to look for, again, is sudden onset leading to an upper respiratory obstruction. Review your processes from your CPR course on the dealing with an upper airway obstruction up to including starting chest compressions or trying to right main stem it. Meningitis is kind of an ebb and flow. We see this primarily in early fall, late fall or early winter, pardon me. And generally what we're looking at here is you can be vaccinated against meningitis, but a lot of parents, for whatever reason, choose not to. Now, because of kids being vaccinated, we see more meningitis in adults than we do as far as kids. When we see it with kids, it's primarily going to be in schools or in daycares where they're in that confined area and things begin to get passed around very, very quickly. Meningitis is typically a chronic onset, so generally you're going to be looking at anywhere from 24 to 72 hours as far as symptomology. The symptoms begin to accelerate as the disease progresses. Some of the things that we're looking at here is you're going to have a really, really high fever. But again, with infants, because they don't maintain body heat really, really well, that may or they may actually become cold. We're familiar with the stiff neck or the nuchal rigidity. And to assess this, just simply ask your patient to take their chin, put it down on their chest, and ask them, is their neck stiff or does it hurt when they do that? Keep in mind that, again, your patients have not read your book, so sometimes that's there. Often it is there, but sometimes it is not there as well. As far as bacterial meningitis, they're all over the place, and so no single sign is going to be reliable for these patients. Look at the whole patient, in particular, a history of onset. What is the child in school? Are they in a daycare where meningitis has been reported? And then also assess your patient for a history of fever. As we talked about, the nuchal rigidity is the inability of being able to put the chin on the chest because it hurts and the neck is just too flat out stiff. Kerning side you can assess for in this, if you remember, is basically what you're doing is you have your patient lying supine and the hip and knee are flexed at 90 degrees. If they try to straighten the knee out or there is pain in the opposite knee or flexion of the opposite knee, that would be an indication of a positive Kernig sign. And Brudzinski's sign, and basically what we're looking at here is you flex the lower extremities during the flexation of the neck, and I've got a graphic here that kind of illustrates both of these a little bit better. I would tell you to make sure that you're familiar with these two different types of signs, as you'll probably see them on a scenario-based type of question for your exam. With seizures, basically they can be anything from hypoxic coming into play here, low blood sugars, onset of epilepsy, any kind of trauma can lead into this, especially anything that would reduce the oxygenation. Generally, what we're going to see here most frequently with these kids are going to be febrile seizures. The thing to remember with febrile seizures is it's in a very young child, and generally what we're looking at here is that we see a rapid rise, not how high it is, but a rapid rise in the body temp. The effect that comes about because of the sudden change of body temperature on the brain. Now, the thing to keep in mind, and you can share this with the caregivers, is they're often worried, okay, does this mean my child's going to have epilepsy? Not at all. This is generally a one-time event, but kids with febrile seizures do have a tendency to, or the incidence of febrile seizures does have a tendency to run in families.